In late 2012, the Royal College of Psychiatrists arranged a special workshop for professionals in healthcare who wanted to understand adult ADHD. The result was an excellent day of teaching, which was made into a series of videos. The first of the talks was by renowned expert on psychopharmacology, Professor David Nutt of Imperial College London. The day was arranged by college podcaster Dr. Oves Badat, himself a consultant psychiatrist specialising in adults with ADHD, based in Bristol. These films are new, and we would like to know what you think. We are collecting your responses as part of our research into interactive online training. Click the link that appears below the video to participate in the 2-minute survey. All information collected is anonymous. In this session, Professor Nutt describes the way in which ADHD affects brain function and how the main medications are evidenced to work.
So you've asked me to talk about the psychopharmacology, which is, of course, is a good thing for me to talk about because it's one of the few things I do know a bit about. And okay, good. So those are my interests, if you're interested. And I'm going to talk largely about the evidence which is presented in these guidelines, the BAP guidelines. One of the things I managed to achieve working for the BAP was a whole series of consensus documents, starting with the depression ones. And I'm particularly proud of these. I think these are as good as any guidelines the BAP have ever produced. They're free online on the BAP website, you can download them. And they are being revised as we speak, and a new set of guidelines will come out next year. So you can keep your eyes open for those. But they're not that much change from these, because the field has grown. It's grown in size and it's grown in maturity, but there's not a great deal more in terms of clinical evidence or even research evidence. I also want to make a brief word about UCAN. So UCAN is an organisation that represents people in the psychiatrists and others in the UK who are interested in adult ADHD. It's championing the cause of ADHD treatment and also research. And say Philip is currently the president of the organisation. It runs great training days. It's also beginning to move into research, and it's a very useful resource for you. So this is an editorial they wrote recently in the Journal of Psychopharmacology. Very useful for any of you who want to kind of know what the sort of current thinking is about how services should be set up and actually why services should be set up and funded. And these 3 bullet points essentially are the conclusions of the BAP guidelines in relation to the treatment of adults. You can read them, I'll read them as well. Drug treatment is the first line for adults as insufficient evidence psychological treatments work. However, as in all of psychiatry, drug treatment should always form part of or be embedded within a comprehensive program which addresses the other needs: psychological, behavioural, educational, occupational. And then generally, if you've made a decision, the first line treatment, unless there are other reasons which I'll come to, methylphenidate should be the first choice. And that's probably going to be the conclusions of the next set of guidelines, with the caveats I'll talk about later. So the reason methylphenidate is used as first line is because there's a vast amount of evidence. Over 100 trials, these are the best ones. And essentially they show that the drug is extremely effective, and the effect size is actually quite large, and it's hugely significant. So it's incontrovertible that methylphenidate works. I think this is one of the most solid pieces of evidence in psychiatry, certainly in psychopharmacology. There are variations in terms of individual responses, and the reasons relate to the size of the person, other comorbidities. The effect sizes vary, of course, according to trial design, etc., who rates them. But the biggest one for you is actually, I think, dose. One of the biggest clinical issues that we have to deal with is non-response, which is often due to underdosing. And I suppose as a sort of rule of thumb, by and large, provided there aren't adverse side effects, the dose threshold, the upper threshold, is to some extent flexible. You should push to optimize benefit within the envelope of the constraints of side effects, particularly blood pressure, or other occasional side effects like sweating. But dosing is the thing you need to think most carefully about. And particularly in transition, as people go from adolescence into adulthood, and they get bigger, and unfortunately, they may need more, and people often don't think about that. I want to show you this study, particularly as Susie's not here. This is one of the most remarkable studies, certainly in ADHD, maybe one of the most remarkable studies in psychiatry, because this is a study done in prisoners, published, I think, was it this year, or late last year in the British Journal of Psychiatry. And it shows that in a population that probably has quite difficult, severe ADHD in prison, you can have a very clear and beneficial effect. So what this study shows is two groups. Well, the first group is randomized to methylphenidate, and the second group is randomized to placebo. And you can see this remarkable effect of methylphenidate, the sort of effect that we see in untreated ADHD patients outside prisons. A big effect and no effect of placebo. And that gives you an effect size of over 2. And I struggle to find any effect size like that for any other treatment, with a number of new treatment was just over 1, basically. 9 out of 10 people respond. And when you take the placebo group, as they did, and then switch them to methylphenidate, they also respond. And the effect's enduring. So this is just I suppose, the most graphic illustration we have of how methylphenidate works. And it shows it works even in people who have, in this bizarre environment of prison. And of course, it also raises interesting questions which you may discuss in your workshop as to whether, in fact, they would be in prison if they had been treated before. And a lot of us believe that there's an inappropriate overrepresentation of ADHD patients in prison, largely because they've not been diagnosed and they've been treated through the criminal justice system rather than through the healthcare system. Now, there's a lot of pseudo-concerns in the media about the dangers of stimulants in children, and largely they're exaggerated, but occasionally growth retardation is something you have to deal with as a real issue. But in adults, essentially, those problems go away, and growth is not an issue. And also, this uncertainty of whether methylphenidate or other stimulants might affect brain growth in adolescence is no longer an issue. The brain seems to stop growing by about 27, maybe in ADHD it's a bit later. But certainly beyond 30, I think most of us are fairly comfortable the brain is beginning to shrink rather than grow. And so there's less worry about developmental problems, although again I would say that the evidence that stimulants have any negative impact on brain maturity in children or adolescents is still pretty uncertain. But I suppose it's theoretically possible. It's not a theoretical issue in adults. So the stimulants are less of a problem in adults than children. What do the drugs do? Well, they do different things in different people, but they largely improve attention, planning, and motivation. They also reduce impulsivity, and they keep people doing what they want to do, or in many cases get them doing things that they want to do, but up till medication, haven't been able to do, like study and like work. And over my career of about 20 years treating adult ADHD, I've treated people from all walks of life, including in Bristol quite a lot of university people, and also doctors. And I don't think any profession needs to be debarred. I don't think I've ever treated a lawyer. But some of you may have. How do the drugs work? Well, we know a lot about them. We know a lot about them, of course, largely because of the fact that some of them are abused, or particularly, well, their stimulants are rather akin to very abused drugs like cocaine and crystal meth. So there's been a huge amount of study on stimulants, so we do know a lot of what they do. And essentially they do this, they increase dopamine and or noradrenaline in the brain. And the way they do it is shown on this cartoon. And this is a dopamine neuron, a schematic of a dopamine neuron. Cell bodies in the substantia nigra ventral tegmental area projecting up into the areas of interest, largely the prefrontal cortex, possibly the ventral striatum. Dopamine works on 5 different postsynaptic receptors, and it's probably some combination of the DA1 and the DA2 stimulation which leads to the beneficial effects in ADHD. And what stimulants do is that they They block the reuptake, so any released dopamine hangs around in the synapse longer. And amphetamines may reverse the transporter here and possibly here as well. And certainly there is some evidence of a functional difference between stimulants in that methylphenidate, the effect of methylphenidate on dopamine release is more dependent on dopamine self-firing than are the effects of amphetamines. So amphetamines can work even when the dopamine cells are relatively dormant. It will release dopamine without necessarily requiring self-firing. Methylphenidate effects are more tied to self-firing. And that's one explanation as to why the drugs are not identical. So that's if someone doesn't respond to one, you might want to change to the other because they're not identical, although they are very similar. And we know that this is now true in humans because we're able to image the effects of stimulants in terms of dopamine release using PET scanning techniques. And illustrated on the left-hand side here, the technology is that you put in a radio-labeled tracer. Usually in the case of dopamine, we use raclopride. Raclopride binds to the dopamine D2 receptors. So here the blue blobs are raclopride. If there's not much dopamine present, there's lots of raclopride binding, therefore you get a hot signal from the brain. And if you release dopamine with a stimulant, you get more dopamine in the synapse, so there's less raclopride binding, so you get a colder signal. And you can essentially estimate the effect of stimulants to release dopamine using this technology. And dopamine currently is the only neurotransmitter we can reliably measure the release of in human brain, and that's because of this approach and the characterization of this using drugs like methylphenidate. Now, when we're looking at the dopamine systems in the brain, there are two pathways. The large one here, about 80% of all dopamine, is the one that goes from the substantia nigra to the basal ganglia. That's the one which is obviously damaged in Parkinson's disease, and it's involved in motor function. But there's this other pathway which goes from the ventral tegmental area into this region here, which is called the nucleus accumbens, or the ventral striatum, and then into the prefrontal cortex. And that's the one that is largely, we think, responsible for the beneficial effects of stimulants. Because dopamine, particularly in the prefrontal cortex, is critical for attentional processes, maintaining optimal levels of attention, and also planning. And the way I conceptualize the disorder of ADHD is like this. That you'll have these two parallel systems, the one from the ventral tegmental area to the prefrontal cortex, the one from the substantia nigra to the basal ganglia. And normally, the prefrontal cortex regulates the activity of the basal ganglia. And in ADHD, you have a relative deficiency of dopamine function in the prefrontal cortex. That immediately leads to inattention because dopamine is critical for optimal attention. And we know that even at the single cell level from recordings in monkeys. But that deficiency of dopamine in the prefrontal cortex then disinhibits the basal ganglia. And that's why you have hyperactivity. And that's this paradoxical effect that you actually have, in a way, more dopaminergic activity in terms of locomotor activity, hyperactivity, in the face of a deficiency of dopamine. And so the way the drugs work is that they, this is just to clarify this. So basically, if you get this reduced inhibition to the basal ganglia, you get excessive activity, what I just said. And what stimulants do essentially is to put dopamine back into the prefrontal cortex, dealing with the attentional problems, and also providing the appropriate level of descending regulation of the basal ganglia to control hyperactivity. So that deals with this so-called paradox of how a stimulant can calm you down. And it's because it's putting dopamine into this part of the brain, and that's the part of the brain which regulates motor activity. So I hope that's clear, and I find that very useful in terms, certainly I find it very useful in talking to journalists and sometimes useful talking to patients. Now, of course, that's a theoretical approach, and it's really interesting question is, can you show that this is what happens in the real world in patients? And I just wanted to show you these new data from the group that is at the Institute of Psychiatry, Capture Rubio's group. They've used imaging to look at the interaction of methylphenidate and the dysfunctions that they have shown in methylphenidate. And this is a very elegant piece of work. It uses neuroimaging to ask that question: what's wrong in the brain in ADHD, and how does it get normalized? And just look at this image here. Basically, this is looking at the amount of brain you need to engage in a task with people with ADHD before they get treatment and after. And you can see before they get treatment, they have to use a lot of brain power, a lot of brain region, large amount of activation of the brain in order to do the task properly. And after methylphenidate, there's much less activation. And so the simplistic explanation is that methylphenidate makes the brain more efficient. And they were also able then, and this is a paper you might want to look at, they were also able then to look where the major interactions were between the effect of methylphenidate and the improved performance. And they showed a variety of regions, and I'm not going to go into what they might be doing, but certainly some of them are consistent with the idea that you're dealing with sort of executive functional changes. Now, one of the challenges we have, though, is that there's not a lot of dopamine in frontal cortex. And that may be why it's so sensitive, why the effects of stimulants are so obvious. I mean, they actually occur in everyone. Anyone who takes a stimulant will have, obviously, a degree of increased awakeness for a period. So it's very interesting and challenging to study dopamine in prefrontal cortex, because this is an image here showing the relative density. There's virtually no detectable dopamine receptors in prefrontal cortex, certainly hundreds of times less than there are in the basal ganglia, and that's a challenge. And until recently, we couldn't be sure that methylphenidate did actually release dopamine in prefrontal cortex. But using a new tracer, this is this one here, which gives you a better resolution of dopamine receptors outside the basal ganglia. So here's the raclopride image. And this tracer here, FLB457, you see it picks up dopamine receptors outside. Here's the thalamus here. And if you've got the eye of faith, you can see there are some receptors here too. So people have started to use this to estimate dopamine release in other parts of the brain. And this is work from a colleague of ours, Andy Montgomery, who was working at the cyclotron unit a few years ago, showing that methylphenidate does indeed increase dopamine release in the prefrontal cortex, as shown by a relative displacement of this other tracer, FLB. So this is the first proof that methylphenidate does actually do what it's supposed to do, where it's supposed to do it. And then recently, the group at the Institute of Psychiatry, the same paper as I showed you, the functional images, they've also done, I think this is phallipride imaging, to show the same thing happens in children. So I think we can say fairly clearly now that the stimulants do release dopamine, and they do it in the part of the brain where we think stimulants work to improve attention and concentration. Now, atomoxetine, of course, is a different drug, and atomoxetine statera has a different functionality to the stimulants, and it works simply on the noradrenaline reuptake side. So it works not directly on dopamine at all. However, it turns out that in the prefrontal cortex, blocking noradrenaline reuptake does have an impact on dopamine function. So if we just go over to this side, what you see here is the effect of atomoxetine to block the reuptake of dopamine, because in the prefrontal cortex, dopamine is largely taken up into noradrenergic neurons, and that is because the prefrontal cortex is an enormous part of the brain, and the dopamine innervation is much less dense, so that there are essentially relatively few dopamine terminals into which the dopamine can be retrieved. In a way, the prefrontal cortex has outgrown its dopamine supply, but there's a lot more noradrenaline terminals there. So a lot of the released dopamine is taken back up, released into the noradrenaline terminals, and that's blocked by atomoxetine. So atomoxetine effectively increases noradrenaline and, to some extent, dopamine in prefrontal cortex, which of course is where you want dopamine increase. Now, the interesting thing about atomoxetine is that because it doesn't block dopamine reuptake, it doesn't increase dopamine in the ventral striatum. The ventral striatum is the area of the brain where the implication is that addiction derives. So one of the goals of treatments is to try to target treatments of prefrontal cortex without enhancing dopamine in that striatal nucleus accumbens region. So atomoxetine does that. And therefore it can never be reinforcing, because stimulant reinforcement is always driven through dopamine release in the basal ganglia. So atomoxetine has this extra safety level because it cannot release dopamine where dopamine can be pleasurable. So it is very different from stimulants in that regard, but it does elevate dopamine in the prefrontal cortex where it's necessary. And there are studies, here are a series of studies that have that looked at the effects of, this is the Michelson study, the first major study, that looked at atomoxetine's efficacy, showing it works across both patient and self-report, etc. scales. And one of the other important things to say about atomoxetine is that it works because it doesn't release dopamine, and because the effects on dopamine are indirect, and because for reasons we don't fully understand, noradrenaline system adapts to uptake blockade in a different way to the dopamine system. And there's a delayed response to atomoxetine. It doesn't work instantly. You have to stabilize someone on it for a period of between 3 and 6 weeks to really be sure whether it's actually producing an effect. And when you do that, the longer you keep people on atomoxetine, the bigger the effect. And this is a very important clinical point. So when you're engaging someone in therapy with atomoxetine, it is like starting someone with OCD, for instance, on an SSRI. You would always explain to them it's not going to work instantly. And one of the challenges with atomoxetine is keeping people in treatment long enough to find out if it works. But the best way of doing that is to start with a relatively small dose, build up to your optimal dose over a week or so to minimize side effects, and then make sure they stay on it. Because if they do stay on it for 6 to 8 weeks, then you are confident in that you've given them a proper trial, and if it's worked, you can carry on. If not, yeah. But a lot of people drop out sooner because they don't get an immediate benefit. They may have had an immediate benefit from stimulants, but also they get side effects. They get sweating. They may get nauseous. So it needs more therapeutic engagement by you as a treating physician with atomoxetine. But if you do keep them on it for long enough, then you may well see good benefits. And overall, there's no real difference between the outcomes on atomoxetine and methylphenidate if you look at these comparative studies. What about beyond those two main lines of treatment? And the only other drug that's worth thinking about probably is bupropion. Zyban, now of course it's licensed in this country as an anti-smoking agent. In most countries it's licensed as an antidepressant as well as an anti-smoking agent. But you can use it. It may have some utility in patients who have a history of abuse, drug abuse, and whom you're trying to avoid stimulants. Atomoxetine may not have worked. It's worth thinking about bupropion. At the very least, it may stop them smoking even if it doesn't cure their ADHD. Just want to touch on a couple of the issues which have come up in relation to adult psychiatrists treating ADHD. I mean, I've heard a number of sort of justifications as to why my colleagues don't want to do it, and these are some of them. They say it's too specialised. It's actually the commonest psychiatric disorder after anxiety. The recent European Brain Council survey showed about between 4 and 5% of the European population has ADHD, so it's very common. It's just that we don't bother to diagnose. We haven't, up till now, bothered to diagnose it. The drugs are illegal, and therefore they must be highly abused. Now, they're not particularly abused, and I'll show you that in a second, but also they're, many drugs are illegal if they're used illegally, and that shouldn't be a reason for not prescribing them. The prescriptions are actually, it's a bit of a chore writing out the number of tablets and words and letters, but most psychiatrists should be able to manage that. Although I do get it wrong on occasions. The transition's a challenge, of course, and that's one of the big one of the reasons we actually set up the BAP guidelines in the first place was trying to help people through that. We still haven't fully cracked that problem. And then this comorbidity issue. And this is perhaps the most challenging one to adult psychiatrists because so many of our patients are comorbid. And I'll just talk briefly about that, but I'm sure Philip will talk more about that. So I just want to briefly touch on this abuse question, and I just want to remind you that stimulants didn't used to be seen as a bad thing. In fact, stimulants were seen as a good thing. Here is an advert in the US press recommending that families sent their soldiers Benzedrine to help them fight the Pacific War. And in fact, I like to wind up politicians by saying that the free Western society, the free world, was actually saved by amphetamine sulfate because the British soldiers in North Africa defeated the Afrika Korps largely because they were able to control their day-night activities using amphetamine sulfate, and that was a turning point for the war. That doesn't go down very well with some politicians, but it's true. But after the war, what happened? There was basically in the war, every combatant was on stimulants. And after the war, there was this glut of stimulants, and kids particularly, started abusing them. So there was this hysteria in the 50s about amphetamine abuse, amphetamine psychosis, and the drugs got made illegal, and also they were supplanted by antidepressants with the uptake working sort. And they got controlled, and now they've become sort of vilified as evil drugs, even though, as I say, they were once seen as the salvation source. And the question of whether using stimulants in children that leads to long-term increases the risk of drug dependence is a very controversial one. The people that don't believe in ADHD believe strongly that we're addicting our kids. And the good news is that there isn't any evidence for that. This is one of the more detailed analyses Willens and colleagues published in 2005, looking at 6 or 7 studies here, and they found a decrease. They found overall treatment of children with stimulants reduced the likelihood of them going on to having drug dependency. Now that's kind of both interesting and obviously paradoxical. And the reasons for that are this, really. One of them is that if you treat people, particularly children who are failing in society, failing in school, they're going to get more rewards, more reinforcement from the other things they do. If they actually succeed at school, they don't necessarily need to look for other ways of amusing themselves or rewarding themselves using drugs. And one of the most critical things, and that's exemplified by that study in the patient population. So many people fail in life because they have ADHD, and that failure leads to drug taking, because if you're excluded from school, there's not much else you can do apart from steal and deal drugs. So school exclusion is something that absolutely must be avoided at all costs, particularly if it's due to ADHD. And Susie Young and the UCAN group are working very hard to try to have a quality of care metric in this country whereby the second school exclusion leads to an inevitable, necessary assessment for ADHD, because they believe, and I very much support them in this, that if you can, those children are going to have be at a very high risk of ADHD, and if you can treat them and keep them in school, you're going to stop them going to prison and stop them taking other drugs. So there's all the sort of benefits of the drugs itself in terms of personal achievement, but there's also the fact that the drugs we use probably reduce the effects of the street drugs. So if you're on methylphenidate, cocaine is going to be less effective. So you're actually going to be less likely to get hooked on cocaine or crack or crystal meth. And again, the reasons for that relate to the interaction here in the dopamine system, particularly this region I've mentioned already, the nucleus accumbens, where the reinforcement effects of stimulants are affected. And this is another really useful slide for you when you want to deal with patients or the media or anyone's concerned about abuse liability. Because in reality, with any drug, but particularly with stimulants, the only drugs which are liked are the drugs which get in the brain very fast and produce very high levels, either of the drug or of dopamine. So these are drugs like smoked or injected cocaine or crystal meth. If a drug doesn't peak in the brain within half an hour, it's very unlikely to be liked. And even oral amphetamine or methylphenidate doesn't peak till between about 45 minutes and an hour. And of course, the slow release versions, they don't peak till even later. And there really is very, very little evidence that people actually enjoy using oral stimulants, and the street value is very low. I mean, of course, there is the possibility you could crush an immediate release tablet and snort it, and that does happen, but it's not a big problem because, in fact, it's so much easier just to go and buy some real Speedons. And if you really are worried about this risk, then you can use a prodrug. Lisdexamfetamine is a prodrug. It has to be metabolized in red blood cells in order to release the active component. So it takes even longer to get an effect. So if you're worried, you could use this. There's also another factor, I just want to share this with you because it's not well known, but it's an important aspect in the whole of psychiatric prescribing, is that the blood-brain barrier is different for different drugs, and that changes the way in which drugs work. And I just want to share this with you because no one else will, and you'll probably never hear it again, so it's my one chance to promote this sort of technology of microdialysis. Here's a rat, and this rat it's got dialysis probes in its blood and its brain. And what this study shows is that you give the rat cocaine, and you measure the level of cocaine in the blood, the blue lines, and the level of cocaine in the brain, the red lines. You see cocaine within 20 minutes is 5 times more concentrated in brain than blood. And that concentration of cocaine in the brain leads to a 10-fold increase in dopamine. So cocaine gets in the brain very fast, in high concentrations, and produces big effects on dopamine, which is why it's abused. Now, methylphenidate, here's blood, here's brain. So it's the reverse. There's only about 1/5 of the methylphenidate. The brain levels are 1/5 of those in the plasma, so it's exactly the opposite of cocaine. It gets in the brain badly and slowly. Eventually, when it gets in, it does elevate dopamine. Here's 7-fold elevation of dopamine. But you see there's not the immediate peak. It peaks here at 2 hours. And that is why oral tablets of stimulants are really almost never abused, because they just don't do it fast enough in order for people to get any kind of immediate rush, which is what they want. And here's some very new data, just not even published yet, but shown at the BAP meeting this year, lisdexamfetamine. And here you're looking at both the rise of dopamine and noradrenaline following an injection here in the rat. And you can see again, lisdex is producing, sort of getting into a sort of therapeutic a level of dopamine and noradrenaline release, not till again about 2 hours. So this proves that if you're worried about abuse, you can always avoid it by using slow release preparations. And one of the interesting side effects of PET studies is that they've actually also given us some evidence that the same is true in humans. So here is radio-labeled cocaine. This is given intravenously, and you see it's collecting in the basal ganglia within 3 to 4 minutes, and it's peaking between about 6 and 7 minutes. So in humans, cocaine does get in the brain fast. We know that because people tell you, but here's proof. And methylphenidate, even when you give it intravenously, gets in the brain more slowly. It doesn't peak till about 10 to 15 minutes. So there are intrinsic differences in the drugs, and methylphenidate is not kiddie coke. It's has a very it's fundamentally different in terms of its kinetics with cocaine. And the cocaine is a particularly light drug because of its kinetic properties. Now the other question is, well, if we are taking or giving our patients these drugs for long periods of time, will the dopamine system change? Will it be a case that people will become more wanting of drugs because the chronic use of these drugs leads to changes in dopamine? And this is again another really recent paper that is a beautiful paper because it actually shows that at least in our nearest primate relatives, that's not the case. So essentially they use methylphenidate in the long term in monkeys, and then they show there was no difference. The ability of the brain to release dopamine to methylphenidate is unaltered when you're on chronic methylphenidate, which of course is kind of what we knew already, because otherwise the drugs wouldn't keep working, and they do. But here's proof that the stimulant still works even when you've been take it to a monkey for a long period. And these monkeys don't show any increase in liking for cocaine, just like our patients don't show any increase interest in drugs. So I think, we've now got very strong evidence, preclinical evidence, to support what we've been doing clinically. There are one or two other factors that we need to bear in mind. The whole role of noradrenaline in ADHD is coming to the fore. Noradrenaline seems to play a sort of parallel role to dopamine in regulating impulsivity, and also potentially in terms of maintaining attention. And as I've already mentioned, noradrenaline as a target is one that's even less likely to be abused than slow release or other forms of methylphenidate or amphetamine. And I'll just show you these are data using another PET tracer. This PET tracer binds to the noradrenaline uptake site. It's a derivative of reboxetine, which is of course an antidepressant that you presumably would have used, and atomoxetine binds to the same site as well. But what this study shows is that methylphenidate also binds to the noradrenaline uptake site. So it may be that there are noradrenergic elements in the actions of methylphenidate. And here's a dose response curve from this study. You'll see there's a huge variability. And this is partly due to the tracer not being a very easy tracer to work with, and partly presumably due to individual variability. But it's likely that in some people, the effects of methylphenidate are mediated in part by increased noradrenaline, in part by increased dopamine. Whether the same is true for amphetamines, no one's done the study. Possibly it is true. Just one comment. I want to show you this picture. I like this picture very much because this really does get to the real epidemiology of the transition. And it shows that this is the proportion of people staying on treatment from the age 15 to 22. And these are the ones that should stay on it based on what we know about the natural history of the disease. The disease tends to remit in some people as they go through teenage years, but people staying on treatment, the decline is much faster than the natural recovery from the disorder. And that, to my mind, that proves these drugs are not abusable. Because if these kids like the drugs, they wouldn't come off them. And in fact, those of you who work with adolescents know that the biggest problem in dealing with ADHD in adolescents is actually to get them taking the drugs, even when they do work. Comorbidity, well, another big question. The fear that stimulants may aggravate psychotic symptoms, which of course they might do if people took huge amounts of them. In practice, if you're psychotic and are antipsychotic, stimulants don't worsen. Same true for bipolars. You can treat ADHD, bipolar is a very common comorbidity. If you're a mood stabilizer, using a stimulant or atomoxetine, perfectly acceptable. Anxiety, depression, not a lot of work done. It's clear that stimulants are not good antidepressants. It was right when they got substituted by the tricyclics in the 50s and now by the SSRIs. But you can certainly get good effects of adding SSRIs to stimulants with people with depression or anxiety. And that, again, is a very common comorbidity. And there's one final word about addiction, because a significant proportion of people in addiction services or people abusing or misusing stimulants are doing it for self-medication purposes. And there's fascinating work now showing that people who use crystal meth actually function better on crystal meth, probably because beforehand they did have ADHD and the drug is actually normalizing or rectifying some of the deficits in their brain. So you have to be very aware of this, and you have to think very carefully about how you deal with those kind of patients. And it's completely appropriate to prescribe to people with a history of drug misuse if they've got ADHD. In fact, my clinic in London now is the ADHD patients. 50% of them are crack or heroin users who've got severe ADHD and are now managing to control their lives. They're still on methadone. But they're no longer on crack because they're on Concerta or other slow-release stimulants. So it's perfectly possible to treat people with a drug problem with ADHD, and you can treat them together, and they can often do extremely well. So it's not either or, and it really, that overlap is so profound that you have to be comfortable dealing with it. Also, one last point: there is obviously a small number of individuals, and you're not sure when you first assess them, are they just coming, are they actually going to start, just like they might be selling the methadone if they're coming to you with with heroin dependency? Are they actually just coming to get stimulants so they can flog? And I've pointed out already, the street value of these drugs is not very high, but there may be some. And if you are concerned, if you're concerned kind of from a medical legal sort of perspective, then start with atomoxetine. Because then if that works, no problem, and if it doesn't work, at least you've tried. You're not being seen as a sort of, as a irresponsible prescriber. So I would conclude then, ADHD is a very treatable disorder. Stimulants, atomoxetine, are effective. They've got different side effect profiles. We now know that they seem to rectify the underlying brain deficits, so they're targeting the problem. They're not just symptomatic treatments. And stimulant abuse is not a big problem. It's very easy to get much better quality stimulants on the street, so it's not something, it shouldn't put you off prescribing if prescribing is appropriate. But as I said, there may be circumstances where you want to start with atomoxetine, just to reassure yourself that you're not being duped into prescribing stimulants. Thank you very much.
We hope you enjoy the clip. Remember to click the link below to give your feedback.